The epiphyseal plate, otherwise known as the growth plate, appears between the metaphysis and the epiphysis during development of long bones. The transcription factors and signaling pathways in bone maturation give us insight to the development and formation of the skeleton. It is a crucial area in adolescence that can be severely affected if fractured. Injuries to the growth plate cartilage often lead to bony repair, resulting in bone growth defects such as limb length discrepancy and displacement deformity in children. There are a number of case studies that represent this abnormal regrowth. Currently utilized corrective surgeries are highly invasive and limited in effectiveness. There are no known biological therapies to induce cartilage regeneration and prevent the undesirable bony repair. In the last 2 decades, studies have investigated the cellular and molecular events that lead to bony repair at the injured growth plate, including the identification of 4 phases of injury: inflammatory, fibrogenic, osteogenic, and remodeling. Mechanisms that play an important role in the osteogenic response are inflammatory cytokine TNF-A, mitogenic factor PDGF, BMPs, and WNT beta-catenin signaling pathways. Recent advances in cartilage tissue engineering highlight the promising potential for utilizing multipotent mesenchymal stem cells, or MSCs, for inducing regeneration of injured growth plate cartilage.
Bone morphogenic proteins are key regulators for skeletal repair. In particular, BMP2 is consistently upregulated during the initial stages of bone fracture healing and, as shown by mutant mouse studies, is critical for fracture healing. In addition to its role in the recruitment of osteoprogenitor cells into a bone fracture site, BMP signaling is ultimately required for cell differentiation into osteoblasts. A study of a rat growth plate injury model has also identified the BMP signaling pathway as one of the most active pathways during the osteogenic phase of the bony repair of the injured growth plate. Wnt's beta-catenin signaling pathway is also important for growth plate bony repair. In a rat model study, levels of beta-catenin were found to be significantly upregulated at day 4 in comparison to day 8 post-injury, and the Wnt beta-catenin signaling pathway was identified as one of the most active pathways involved in the growth plate bony repair.
Situated under the epiphysis at the ends of all long bones in an immature skeleton, the growth plate holds the sole responsibility in achieving longitudinal growth. It functions to produce a mineralized cartilaginous scaffold to which new trabecular bone is formed via a tightly controlled 2-step process involving chondrogenesis and osteogenesis. The growth plate consists of organized zones of chondrocyte proliferation. These chondrocytes secrete extracellular matrix composed of various collagens and proteoglycans. Upon differentiation, they become hypertrophic, undergo apoptosis, and are replaced by bone cells. Transcription factors, along with growth factors, circulating hormones, and surface receptors, aside from extracellular matrix components, also regulate normal growth of epiphyseal plate cartilage. The growth plate is made of 4 distinctive zones: the resting zone, the proliferation zone, pre-hypertrophic zone, and the hypertrophic zone. The resting zone has previously been thought to play a very minimal role during endochondral ossification, as the prechondrocytes within this zone proliferate minimally. However, studies have indicated the importance of the resting zone as it acts as a reservoir of stem cells or prechondrocytes for the developing chondrocytes in the adjacent proliferative zone. The proliferative zone is responsible for matrix production and cellular division during endochondral ossification. The height of the proliferative zone directly correlates with the extent of longitudinal growth that can be achieved by the long bone. The hypertrophic chondrocytes produce collagen 10, which is involved with matrix mineralization. Together with the action of growth factors produced by hypertrophic chondrocytes and a low oxygen tension, the hypertrophic zone attracts blood vessel invasion from the adjacent metaphyseal bone, which bring along mineralized cartilage resorptive cells, bone-forming cells, and bone resorptive cells to convert the mineralized cartilage scaffold into trabecular bone in metaphysis.
The growth plate is often an injury-prone area as it is the weakest region of long bone and cartilaginous in nature. Past and recent data have shown that approximately 15 to 30% of all childhood skeletal injuries are growth plate related. Physeal injuries can be classified by the Salter-Harris system. These fractures require special attention because not only are they relatively common, but in addition to this, incorrect initial treatment can result in complex, progressive, angular deformity, secondary only to growth arrest. Therefore, early recognition and proper management is key. In the article, Growth Plate Injuries of Lower Extremity, Case Examples and Lessons Learned, growth plate fractures in children and their implications are examined. One significant case examined a 14-year-old boy who presented with deformity in a shortened left lower extremity caused by initial injury from a motorbike accident 8 years prior to the presentation mentioned. At the time of injury, the boy experienced a traumatic open knee joint procedure to repair soft tissue injury and growth plate injury of the medial aspect of the knee and lower thigh. No fractures were noted in his initial radiographs. This initial injury was consistent with a missed medial Salter-Harris 6 perichondrial injury, which was added to the classification system later, given the initial accident scalping mechanism and consequent growth arrest medially, resulting in recurrent displacement despite realignment osteotomies. The patient presented with a history of multiple femoral and tibial osteotomies, operations where bone is cut to be shortened or lengthened or to alter alignment. Radiography confirmed an 18 cm leg length discrepancy in addition to lateral displacement of 28 degrees of the left leg. Physicians then planned for a 2-level osteotomy, gradual lengthening of bone, and deformity correction of femur and tibia and external fixation. The patient followed up regularly during realignment phase, with the correction schedule adjusted accordingly. 10 months after fixator application, after demonstrating successful healing and alignment, the device was removed. Follow-up radiographs showed femoral and tibial sites consolidated, and lower limb alignment and leg length discrepancy was surgically corrected.
It is clear that fractures to the epiphyseal plate can cause severe deformities. This is especially alarming for those diagnosed with osteogenesis imperfecta, in which they are more susceptible to experiencing growth plate formation deficiencies. Osteogenesis imperfecta is a genetic disorder that arises in fewer than 20,000 new cases per year. This disease, caused by defective genes, affects the formation of collagen, crucial to growth plate formation as mentioned previously. Bisphosphonates are widely used to treat children with osteogenesis imperfecta. Bisphosphonates are deposited onto the surface of the bone, where their endocytosis by precursor or mature osteoclasts induces cell death. The major intent of administration of bisphosphonates in OI is to decrease fractures. However, trials and studies have not supported a statistically significant effect of bisphosphonates on fractures in OI. Bone quality is reduced by long-term bisphosphonate administration, as seen in mice models, causing increased bone brittleness. As a result, researchers are now testing 2 novel drugs with anabolic action that act as antibodies to sclerostin, a negative regulator of bone formation in the Wnt pathway, and to transforming growth factor beta, a coordinator of bone remodeling produced by osteoblasts. Treatment models in mice with these experimental drugs have been shown to increase bone mass and decrease brittleness.
In this study, researchers intentionally injured the growth plate of a rat to observe how it would repair itself. Different phases of injury repair lead to the undesirable bony repair, namely the inflammatory, fibrogenic, and osteogenic and remodeling phases. The inflammatory phase involves an infiltration of white blood cells into the growth plate injury site and upregulation of inflammatory cytokines and mediators playing an important role in modulating downstream healing responses following growth plate injury. The fibrogenic phase has been observed on days 3 to 7 post-injury in rat-injured growth plate, involving an influx of vimentin immunopositive mesenchyme cells. At the growth plate injury site, some of these cells were found to express growth factors, including bone morphogenic proteins, platelet-derived growth factor, and fibrogenic growth factor, along with receptors for BMPs and PDGF. Potential multipotency for some of these cells suggests that differentiation of these cells and growth plate repair outcomes could be influenced by some growth factors or other signals occurring during this phase.
Bone formation has been observed to commence around 7 days post-injury with appearance of bony trabeculae, and bone remodeling has been observed at day 14 with the appearance of bone marrow cells. During the osteogenic phase of the growth plate injury repair process, the cells within the repair site have differentiated into osteoblasts and produce increased levels of the BMP osteocalcin. During the bone remodeling phase, levels of osteocalcin mRNA expression were found increased, and expression of chondrogenesis-related genes were lacking. Overall, the most notable components involved in bone fracture healing are both BMP and Wnt beta-catenin signaling pathways. These are each important factors in regulating the growth plate bony repair.
It can clearly be seen that there are serious implications resulting from growth plate injuries, including incomplete long bone growth, leading to length discrepancies and angular deformities. In order to effectively diagnose and treat these impairments, it is important to understand the epiphyseal plate anatomy, development, and signaling. Only when these are understood do we have a chance at finding a long-term solution for growth plate injuries.